Greetings to everybody, and thank you for joining this great conversation. My name is Lopa Banerjee, and I'm the Executive Coordinator of the Generation Equality Forum at UN Women, and also the Director of the Civil Society Division at UN Women. And it's really a privilege to be able to address you, and I look forward to the discussions and indeed to this gathering, to this seminar that is on for these days. Unfortunately, and I apologize in advance, unfortunately, I am not going to be able to stay for the duration of this meeting. This is a really busy period with multiple things going on. As you know, we are just a month and a half away from the forum in Paris, so my life is not my own, but my fabulous colleagues Nazneen Damji, who actually is the focal point as well, together with Kate, will be there for the rest of the session, and they are the movers and shakers for the Action Coalition on Sexual and Reproductive Health and Rights, Bodily Autonomy, and SRHR for the Generation Equality Forum. But welcome to everybody, and to this really important conversation on how do we build a gender responsive COVID recovery, in particular on SRHR. What are the issues that we need to be addressing? What is the investment that is needed? How do we understand and advocate for integration of SRHR services in national health plans and policies? And how do we expand access to marginalized groups? This is absolutely crucial, noting also that we have new numbers among the marginalized groups as a result of COVID. And overall, what is the way in which we are going to address the severe gender inequalities that have resulted from COVID on top of what already existed? And we have an amazing set of experts, activists, leaders to lead us through this conversation, which my colleague Nazneen Damji will moderate after I leave. Camila Fernndez, welcome to you. Camila is a trans advocate, and she is a She Decides 25 by 25 young leader. Thank you, Camila, for your participation and for your leadership and activism. We have Ann Biddlecombe, who is the Director of International Research at Guttmacher Institute, and we look forward to your contribution, and in particular to the research that you recently conducted and that you will be sharing. And to Elizabeth Adelina Sidabutar, who is the humanitarian program analyst at UNFPA in the Indonesia country office. Thank you so much for joining this conversation. Colleagues, COVID-19 has not only highlighted and illuminated the gender inequalities that already existed, but has also exacerbated them. And while we have all been talking about building back equal, building back better from COVID, what we are seeing right now in terms of the COVID response plans is that this build back or equal or better is not comprehensive. And my colleague Nazneen will speak to this a little bit later when she starts the moderation, but the global COVID-19 gender response tracker, which was launched by UNDP and UN Women in September 2020, and currently covers 3,112 measures across 219 countries and territories, looking at what these COVID build back policies are addressing in terms of gender equality. And noting also that not all countries are reporting back on all parameters. But that said, what we are seeing is that the response is not holistic across the majority of countries. But I won't go into details on this, and I will let my colleagues speak to this a little bit later. And even though we're not tracking sexual and reproductive health and rights per se, we are tracking gender-based violence, we are tracking economic justice, we are tracking leadership, and these intersect with the SRHR agenda frontally and crucially, as we know. What we also know, all of us who work in this area, is that SRHR rights issues and considerations have been particularly affected by COVID. Health workers have been reassigned away from sexual and reproductive health, or have been lost entirely due to illness, death, or burnout from how they have had to deal with the pandemic. And of course, gender-based violence has and the response in some ways to gender-based violence has drawn away services from SRHR, and gender-based violence has increased exponentially during this COVID period, and that includes SRHR-related gender-based violence. The Generation Equality Forum that is taking place at the end of June, 30th of June to the 2nd of July, centrally focuses on what does a gender equal response to COVID look like. The focus of the forum is crucially on bringing together multiple stakeholders across intersections, across sectors, intergenerational leaders across sectors, so as to be able to develop an agenda of action and implementation that is monitored and that is responsive within a limited period of time, 5 years, that centrally addresses what we are seeing as the fault lines from COVID. And so the forum, as you know, has launched 6 action coalitions and a global compact on women, peace and security and humanitarian action. But what is moot for this conversation is the Action Coalition on Bodily Autonomy and SRHR. And this Action Coalition has prioritized 4 key actions. 1, the increased delivery of comprehensive sexuality education. 2, the increase in the quality of and access to contraceptive and safe abortion services. 3, norm change, so that more than 260 million girls, 260 million more girls, adolescents, and women in all their diversity are able to make decisions about their bodies, their sexuality, and their reproductive choices. And finally, 4, increase accountability to participation of and support for autonomous and women's rights organizations, feminist organizations that are working on these issues and that we know are in many ways the frontline responders, but also the frontline leaders of action on this issue. So where we are right now is the mobilization towards these goals and the drive for commitments across all stakeholders, government, civil society, private sector, UN organizations, philanthropy, so that between now and when the forum opens in Paris, we have a critical set of commitments across these 4 areas with finances, with expanded action, not what we have seen so far, but new policy and implementation actions and new investments across these 4 areas, so that we are able to accelerate the advocacy, the reforms, the investments on this in the next 5 years. And what is really critical about this in relation to this conversation right now is that these commitments that we are calling for across these 4 action areas are aligned with those that are being made in response to the PMNCH's call to action on COVID-19, which brings over 1,000 partners together, as we know, to advocate for urgent action to combat the effects of COVID, including, again, through protecting and expanding sexual and reproductive health and information services and gender-based violence services. So I am sure this conversation is going to be exciting as we look at these linkages, as we look at common advocacy moving into the forum, and as and in terms of not just the actors that are here, but also the actors that all of us work with outside of this conversation, who need to be leveraged and who need to be held accountable so that we do have a Build Back Equal response to COVID going forward. With my sincere apologies, I do have to leave at this point in time, and I'm going to hand it over to my colleague, Nazneen Damji, to moderate this conversation. Thank you so much again for your leadership and for your knowledge and expertise in guiding this conversation forward. Thank you.
Great. Thank you so much, Lopa. That was a really good way to get us energized and started. Thank you so much. Colleagues, we're going to switch right away to hearing from our panelists. What I'd like to remind everyone is that we will open for Q&A and comments after the discussion with our speakers. So please post any questions you might have into the chat, and we will definitely address them as we finish our session with our very our experts here. I would like to start immediately in on a question for Anne. There's been, as Lopa said, this exceptional research done by Guttmacher. And so now we're not in this speculation mode. We've actually got some very hard evidence. So what I'd like to ask you, Anne, is what are some of the trends you're seeing? And what do you think that health systems, in terms of their constraints, how can advocates actually take some of what the data that you've produced, what can they do to advance national level advocacy efforts so that we can see some changes happening? I'm going to give you 5 minutes, please, to answer that question for us. Thank you. Over to you, Anne.
Thank you. And it's so good to be here with everyone in this session. I just want to underline some of the kind of really the energy that Lopa began the session with, and in the basic fact that the pandemic has exacerbated existing inequities in healthcare, including access to a full range of quality sexual and reproductive health services. And the country-specific data that we released bring concise and powerful evidence to speak to these inequities, both across countries and then the challenges for marginalized and disadvantaged groups within countries. So what is this concise evidence? First of all, we take a holistic view, a comprehensive view. So no one service stands on its own. They all fit together. Contraception, abortion and post-abortion care, antenatal, delivery care, addressing major obstetric complications, newborn health, HIV and STIs. And the evidence highlights current levels of need and gaps in coverage, and calls out gaps in particular for adolescents and for people living in more remote rural areas versus urban. It also shows the health impacts of meeting all needs, and importantly, an annual per capita cost at current, I should note, substandard levels of care and coverage, and the additional cost to meet all needs. So building back from this pandemic means using data to ensure that sexual and reproductive health and rights are priority in rebuilding and improving healthcare systems, and to bring us continued spotlight to addressing inequities. For example, in 74 of the 132 countries, at least half of adolescents aged 15 to 19 who want to avoid pregnancy and are sexually active are not using any method of modern contraception. across all 132 countries, when fully investing in sexual and reproductive health services, unintended pregnancies would reduce anywhere between 44 and 92%, affecting millions of people and their families. And in countries where maternal and newborn deaths are high, there would be dramatic reductions. Countries like Chad or South Sudan, Central African Republic, and Haiti would see reductions in these deaths by at least 2/3. And lastly, in nearly all countries, for every dollar spent on contraceptive services beyond the current level, there would be a cost savings in maternal, newborn, and abortion care. In more than half of the countries, 82 out of the 132, an additional $5 per capita at most per year would be needed to fully meet all contraceptive, pregnancy-related, and newborn care needs. So how can this evidence be used to make the case to policymakers, donors, and others for increased investment in sexual and reproductive health and rights? I want to note that, first of all, obviously, country circumstances, including the strength of their economies and health systems, vary greatly. And larger investments are needed in those countries where the need is greatest and health systems the most strained. And this is in part the very definition of inequity versus inequality. And there is no one path, one approach, one single approach, one tool that is appropriate for all countries, given their different needs and situations. But it is important that countries prioritize sexual and reproductive health and rights and adapt and scale up provision of essential services progressively. I think in grappling with the fallout from the COVID-19 pandemic, many countries are working out how to provide affordable, high-quality care to all individuals who need it. And that includes taking steps to shore up access to supplies and medicines, to promote telehealth options, increase funding to global programs, or at least increase the drumbeat to increase funding to global programs that expand access to sexual and reproductive health. And these actions must address the unique needs of vulnerable and marginalized peoples, as they are contending with barriers, not just within healthcare systems, but extending beyond those systems that were exacerbated by the pandemic. So I think the kind of final point in the 5 minutes is to really say that comprehensive rights-based sexual and reproductive health must be a part of these efforts. And I think this evidence that we released for 132 countries, concise, compelling case can help make the case for the investment of resources to get there.
Great, thank you so much, Anne. And I'm sure that the audiences, if they haven't yet checked out the database, are keen now to be able to see some of the actual concrete numbers that you have gathered in terms of being able to identify what would it take for us to actually reach and meet the needs of women and girls. So it's extremely important. And I think that the uniqueness of also capturing the costs to demystify. So as packages are being developed on how to respond, we actually know what it's going to cost. So thank you very much for that, Anne. I will now turn to our next speaker, Ebeth. You work within the context of humanitarian assistance and emergency settings. What are some of the challenges you're seeing? In particular, you're in Indonesia, so you can give us some examples from there in terms of prioritizing and implementing comprehensive sexual and reproductive health services, including gender-based violence services. And over to you, and you have 5 minutes. Thanks.
Thank you so much, Nasmin. Good evening from Indonesia, and thank you so much to be here, and then also listening from other speakers and from the participants. So thank you for the question, Nasmin. The government of Indonesia has applied lockdown since March 2020 actually, and then in June, and sometimes it's the same with the other countries for the restrictions from the areas. So up to now, in 17th of May, I've just checked the data from Ministry of Health that we have 1.7 million COVID-19 cases positive and 48,000 pass away or death. But Indonesia, one of the most prone disaster area, we are consist of 270 million people living here, and 97% are living in disaster prone areas. So we are really have they have the drought, there are floodings, there are tsunamis, earthquakes, and up to now there are more than 4,200 since COVID-19 occurs. There are more than 4,200 natural disaster occurs during COVID-19, and that's affected more than 11 million people displaced during the difficult situations. So this is one challenges in our country. The other concerns is also Indonesia have the high MMR, maternal mortality rates, around 305 per 100,000, and 1 out of 3 women facing physical or sexual violence in normal situations. That's from our survey statistic office in 2017. So during COVID-19, especially during natural disaster emergency settings, it must be increased heightened fastly in Indonesia. So those are some challenges that we are facing now. And as we know, when disaster occurs or strikes, the maternal deaths will be increased fastly. Also GBV cases, including especially for the sexual violence, unmet need for family planning and contraceptives use. Definitely there will be there's a disruption of the support system, or maybe there is no service affected by these natural disasters. Currently, during the COVID-19, the midwives practices are closed, around 900, and then 30 until 40% of family planning services are decreased since the beginning of the COVID-19. So unmet needs is increasingly fastly. But our government has adopted the introducing by UNEPA. There are some guidelines and advocacy works that we've done. So it's fastly responses by the government of Indonesia by adopting the COVID-19 SOPs or integrated into the technical guideline or the contraceptive availability, especially for emergency situations, not only COVID-19, but in natural disasters. We also supported the government through the advocacy and technical advice to ensure that the preventable maternal deaths will be maintained properly. So 0 tolerance for the maternal death and 0 tolerance for the GBV and sexual violence, and 0 tolerance for family planning or arithmetic for the family planning, especially for the contraceptive availability, including even in humanitarian or fragile situations, not only COVID-19, but fragile situations. By having this spirit, UNEPA work closely with the government. UNEPA Indonesia is one of the trusted partner by the government of Indonesia. So closely work with them by adopting the COVID-19 SOPs guidelines from the UNEPA, and then introducing that to ensure the continuity of the sexual reproductive health, prevention of GBV, and continuity of the family planning or contraceptives in emergency settings during COVID-19. So things that we've done is facilitating the assessment GBV impact and sexual reproductive health, and engage with the preparedness, ensuring that we have the appropriate preparedness plans, have the engagement of the community input it into the member of it's called clusters mechanism during humanitarian situations. So by having that capacity available, adopting strengthening the capacity by the SOP to utilize the SOPs and the guideline and SOPs. So when we deploy them during humanitarian situations, they know what to do in 1 or below 72 hours to avoid the sexual violence in emergency settings. Not rare happen in Indonesia. From our experience, is less than 7 days. There are sexual violence occurs in emergency settings, natural disasters, and in current difficult situations. We also introducing the teleconsultations, telemedicines, even in humanitarian situations or emergency situations. The other part that important also and also quite challenging, the midwives needs personal protection equipment. So that's why some midwives close their clinics because limitation of the equipment, the protection personal equipment. So during the humanitarian situations, to ensure that we have the prepositioned initiatives or supplies to ensure that the meet was also occupied by protection personal equipments. Health workforce also have the difficulties in coping their situation. So psychosocial support for them and also psychosocial counseling to the midwives as the first responders for the GBV cases. So this is quite of the important. Maybe the last one, that statement I would like to close this name. The preparedness is very important and the coordination is really important in emergency settings, especially for the humanitarian situation like Indonesia. That's also empowers with the COVID-19 situations. Thank you, Nesnan. Over to you.
Thank you so much, Ebeth. It's incredible the amount of effort that needs to happen in this context. And the context is so critical for us to even think about how do you integrate and ensure integration happens from, you know, the healthcare workforce to the actual access to services, to the innovation using telemedicine. So thank you so much. That was very, very comprehensive. I will now turn to our third speaker, Camila Fernndez. Camila, it's incredible to hear some of your advocacy work, and I think the audience would be very pleased to hear some more from you. But tell us a little bit more about what are some of the challenges facing, particularly the LGBTQI communities in accessing sexual and reproductive health services, and tell us some more about your advocacy work in that area. You have 5 minutes. Thank you.
Thank you, Nasmin. Hi, everyone. How are you? Okay. So one of the specific challenges here for LGBTQ+ community in Argentina are the visibility. First of all, I think that the pandemic, tends to hit things, you know, and it was a problem at the beginning for us being visible, and the pandemic only made this worse. So we noted that there was like an uncontrolled necessity. I mean, the pandemic marked a path, like a start point. So we starting to meet other people from our community that were lack of food. There was a lack of medical check-ins. That, I mean, these things were previous from the pandemics, and the impact of the pandemics only came to make things worse. So even our trans women here, the only income they had were sexual work in the most of the cases. So it was worse even, because you say to everyone staying home, and they couldn't work. So it was really difficult overall at the beginning of the pandemics in March, early in 2020. Another challenge is the mental health. The pandemic affect our mental health, not only to the LGBTQ+ community, but also other marginalized groups like young people. Basically, because for us, to the LGBTQ+ community, there is no other social circle of contentions that our friends or our community partners, and we barely have, I mean, we as the community, right? We barely have access to connectivity or internet to make like Zooms or meetings, etc. So, well, it was really difficult as regards mental health for us. So creating spaces, safe spaces for exchange and connection was also a priority in our activism, you know. Moreover, for our communities and partners of community. These spaces were fundamental to reinforce, our bonds and how we relate with each other. Because if we do not, I mean, the lack of mental health affects us, affects our confidence, affects our way of relate with people, and how we feel, and affects how we feel about us, about ourselves. And if we don't feel good about ourselves, there is no future possible. That's why it's that important. Thank you so much.
Thank you so much. And thank you so much for highlighting for us, also bringing in the whole issue of mental health and the importance of peer-to-peer exchange and safe spaces. I think those are critical points that we often forget in contexts of crisis, and we try to, our eyes are not open to that. And the importance there, again, of stigma-free services and discrimination-free services is critical. So thank you for highlighting those. Colleagues, I'm now going to turn to each of the speakers with one common question. We're knowing and we've heard how COVID has exacerbated inequalities. We're seeing and hearing all about the different structural barriers. We just heard some very critical ones from Camila, inside and outside the healthcare system. So what I'd like to ask you is to share with us what you think is one key way to address gender inequality in national COVID recovery strategies. I'm going to give you all, sorry, we are running out of time. I'm going to give you all 1 minute to answer. And I'd like to start, please, with Ann, if you could share with us your thoughts.
1 minute, one key effort. I think that's a challenging question for all of us. I would say that number one is recognizing that people's sexual and reproductive health needs don't go on hold with the pandemic, and that the impacts are not equal across all people or countries. I would say, let's use the range of evidence we have at our fingertips to push for increased investment in these essential services, both as part of strengthening health systems and also increasing outreach and access to all people, and especially people who are in highly disadvantaged situations or being actively discriminated against. The country profiles I referenced earlier, they show the relatively small per capita investment per year that would be needed, less than $5 per person per year in many countries. So it's a matter of choice. And it's not only a matter of building back better, but also a matter of building back smarter. So I think a question that resonates for the work that my colleagues and other partners do is, what are the things that we can learn from this pandemic? What are some of the harmful policies or practices that were rolled back or stripped away or diminished as countries were grappling with the pandemic? And what are the ways that that services were alternative means to get services and information to people and to support people in exercising their right to health and bodily autonomy that merit retaining, expanding, and even institutionalizing as regular practice?
Great, thank you so much, Ann. And a lot for you, what you're just saying, a lot of it resonates in terms of as we think about preparedness planning and how that's now being thought of as how do you build off of the lessons. So thank you so much for that. I'd like to turn next to Camila to tell us your one key way do you think we need to in order to address gender inequality as we go through national recovery plans. Thank you.
Yes, I share with Ann that it was really difficult to put it only in 1 minute, but I think that the one key way to address this is organization. I mean, organize yourself to organize others. And how can we organize the best way possible? Okay, being empathetic, being an ear when it's needed, being open to everything that our community has to claim. You know, here in Argentina, I would like to spotlight this because it was amazing. We already approved safe and legal and free abortions on last December, and also, we added, we as the country, right? We added the HIV positive people to the target population on the vaccines. And these huge things, we owe this to the organization, the people that claimed for that. And also a government, of course, that had this political decision to accompany the organizations and the people. Only one on I don't know, I by myself, I don't know how to say it, but I can do anything. Only one person can do anything. That's why I say that it's that important to organize the others, because this is where the real transformations happens.
Fantastic, thank you. That is extremely inspiring and critical. Ebeth, I'm going to ask you in 1 minute to share with us your one key way that we can actually address gender inequality.
Yeah, thank you so much, Nasmin. Echoing Ann and Camila, the sexual reproductive health during crisis is not luxury, it's a human rights. It's a human rights, especially during COVID-19. It's become more difficult now because government puts the priorities for another COVID-19 response. And we consider that women do not stop giving birth during disasters as well, like in Indonesia, emergency cases also occurs. Individuals and couples also do not stop needing family planning services to manage their reproductive health and choices. And we know that during difficult situation, health crisis, both COVID-19 and natural disasters, the GBV cases is increasing suddenly and fastly. So for this case, I think preparedness is really crucial, be prepared, because the COVID-19 is we don't know when until when, but natural disasters also, like in Indonesia, always occurs. 97% of our living in prone disaster areas. So preparedness is the key, Nasmin, here. Preparedness for by having the SOPs adapted, very technical, practical SOPs, preparedness, engagement with the community, engagement with multi-sectorals. So the other part is coordination. It's very difficult, but that's the key. We cannot work alone, like Camila said, we cannot work alone. So we have to coordinate with the other part, government, donor development partners, and also community, and also religious leaders, things that we can put in as champion. So I think those two, preparedness and key coordinations, I think that's good. That's one key way that I can share. And also this good practices and lessons learned from Indonesia. We have good preparedness and coordination with multi-stakeholders, including the women-led NGOs, gender and led NGO, HIV-led NGO. So community mobilization and localization is really important. Maybe that's from my side, Nastin, to ensure that women engagement, women empowerment, and prevention on GBV in humanitarian settings will be appropriately managed if we have a good preparedness and coordinations. Thank you so much, Nastin.
Thank you so much. So that's great. Preparedness, coordination are critical as we go forward. I would like to now, and I thank you so much for these thoughts, colleagues. This was a very short time, but you've got some very good concrete thoughts out. I'd like to now open up for some Q&A from the audience. We have a question for Camila from Michael Santos, asking and thanking you and asking about how do you think organizations can better support the mental health of LGBTQI+ communities, and does technology help? So over to you, Camila, for a response.
Yes, thank you, Michael. So it's hard as regards technology because some, as I said before, it can suppose a problem most of times because I don't know if in your country it happens, but at least in mine, we barely have access overall the LGBTQ+ community, which is like a low-income community. So it's hard to have access to internet or cell phones or computers, etc. So the presential spaces or meetings, following the protocols and everything, are the thing that help here to reinforce, let's say, the way we relate, and also it's like a strategy for us to I don't know how to say it, to it's not hug, but being like a contention circle and stop damaging behaviors that may affect us, like drugs or alcoholism, which are a handful, in most, at least in my experience, that happens. So I hope I could answer your question. And yes, it's the Stop Hate Day for us, so it's nice to be here.
Great, thank you so much. I know earlier on in the chat we had actually questions, and thank you, Anne, also for the link to the research that you had spoke of. So thanks for sharing that. For colleagues, check the chat for the link to the research. And also there was a question early on when Lopa was giving her opening remarks about whether the UNDP UN Women Tracker is going to consider tracking SRHR. And indeed, we had thought of that at the time. I think it was just a question of capacities and abilities to be able to provide this data quickly, but definitely would like to explore that with our colleagues at UNFPA in particular to see how we can do that. I think there were some initial discussions, but again, timing and capacities were not within our reach. So we had to shelf that, but I think appreciate so much, Susan, for bringing that up again. Colleagues, the chat and the discussions are still open. If anyone has any questions, anyone wants to share, we have a few minutes left. So let me take the advantage, since there isn't a question coming from our colleagues, our participants, to just ask for thoughts from any of the speakers. What are your thoughts in terms of what are you optimistic about? What do you think can actually be improved coming as we go forward? Anyone want to take that? Just unmute your mic and jump in. Please show me some optimism and hope.
Oh, no, I think what the pandemic has, one of the things that this horrific pandemic has done has shown a bright light on the state of healthcare systems, who they're reaching, who they're not, how they're reaching people, the content of the care going beyond coverage. And it's shown a bright light on it. It's nothing new, and yet it was a situation, I think, that far too many governments and other key stakeholders were comfortable in maintaining. And so that's what one of the, I think, bright lights that is done is shown how valuable all aspects of the healthcare system are, and the kind of the strongest case for investing. And the second part, I think, is that it has, lifting up a point I raised before, is that it has lifted up alternative, let's say, workarounds or other ways of trying to deliver services. And some that merit continuing and expanding. But I also take, Camila, your point to heart in terms of being very realistic and critical in assessing these new approaches or expanding approaches like digital tech, because it is not always accessible and in fact may in and of itself exacerbate inequities.
Great, thank you so much for that, Anne. We do have another question coming through. Colleagues, for any of you, the UK is one of the biggest funders for SRHR due to changes in the aid budget. How do you think the gap will be filled? So any thoughts from any speakers on, it's definitely a challenge, and it's definitely something that we actually don't need right now. So any thoughts from anyone? Yeah, I think it's kind of leaving a lot of us to think about who needs to now step up. How do we address that? That's a difficult one. So we do have another question to the speakers. It's really how can we work in the sexuality of children and teenagers with them, and not about things that they're not supposed to do, and not about the thing that we are supposed to be about their sexuality before the pandemic. So I think, how do we work on the issue of sexuality with children and teenagers in particular in this context? So any thoughts? I think maybe Ebeth, we can hear from you some thoughts in terms of how you think we can work on sexuality with children and teenagers.
Yeah, maybe I also can link with the echoing about the optimistic as well, Nasmin. I'm quite optimistic with this new approach, and Nasmin and maybe the other colleague here, to introducing the strengthening the integration of sexual reproductive health and GBV in the front line, especially introducing that to the midwives, and also integrating that into the psychosocial approach through the midwives, which is because we know the challenges. So I feel confident. It's quite challenging, but I feel confident that the midwives knows that psychosocial support skills are needed, and they notice that the midwives or health workforce also they are frontliners to screen the prevention of GBV or sexual violence, and introducing the referral mechanism to them. So this is a new things that we learned from this pandemic COVID-19, that how we can strengthening the health workforce, including the midwives, during COVID-19 and difficult situation. And for your second question, Nastin, on then how we can teach all children and teenagers on this sexuality, especially during pandemic. This is quite challenging as well. Maybe I echo Camila as well. That's quite hard and quite difficult, realistic. But by having the portal technology things, the more engagement through the IT, maybe that's quite interesting for the youth and children. And having those kind of the engagement could be better. But if you are ask me about the humanitarian settings, usually we have the youth-friendly spaces during emergency settings. So we have the spaces for them, engage with them, empowering them, so they have the meaningful engagement during in humanitarian situations, especially for disaster COVID-19. So they have a trigger to reduce the stressing if we have create a space for them. And they also create activities. It's not expensive by involving youth or children. Just create a space and activities, so it will bonding them and introducing the sexual reproductive health information and creating services for them. Maybe that's all for myself, Nasmin. Thank you.
Thank you so much. No, those are very, very important thoughts. Colleagues, we are running out of time. We actually are out of time. We're at time. So huge thanks to our speakers. We need to be organizing. We need to use our evidence. We need to make sure that we are prepared, and we need to coordinate. Those are the things that I'm 4 words that I'm taking away from this session. Thank you so much. Colleagues, please join the plenary now, as the session is now over. And please stay tuned in terms of the Generation Equality Forum and how you can become a commitment maker. You can check that out on the UN Women website. Thank you so much, and enjoy the rest of the summit. Thank you.